Okay, well, thank you very much for the introduction. Really fantastic to hear Roger roll through so many of these innovative approaches to incorporating advanced imaging into retina care. And now it's time for Big Brother to step up and take the podium to talk about glaucoma. I will introduce, it's been a long run running with Roger here. And here we are as kids and, growing up in the 80s, of course, I'm sitting there thinking that my jacket has a funny lining and I'm dressed in a sweater made of something called velour. And setting the precedent for our lives together, Roger's just thinking, hey, I'll have what he's having. And wouldn't you know, I became an ophthalmologist. Roger followed close behind. I went into glaucoma. Roger made the considerably more intelligent move to move into retina, but we've had a lot of fun together talking eye cases along the way and getting to do other things. I'm not sure what Roger's trying to keep a secret about here, but doing runs and little mini triathlons and things like that. And many of you may know us as being avid Patriots fans, and we've had quite a nice run of that over the past years to come. And really, COVID is likely to shut down at least some element of the football season ahead, and really isn't that just what Tom Brady deserves? So anyway, let me disclose that I am a paid consultant and advisor for ZEISS as well as for other companies, although most of my work gets done through foundation and NIH grant support. So I'm going to talk about not just imaging, but also functional testing that we are delighted to get to do in glaucoma, and talk about how I'm incorporating advanced structure and function testing into my regular routine with glaucoma patients these days. I'll remind our retina audience that glaucoma is a progressive optic neuropathy that's really about the optic nerve and visual field damage. It's really a final common pathway from a number of pathophysiologies. And just to remind all of us that elevated eye pressure is not glaucoma. It really is about the retina and optic nerve where the retinal ganglion cells and their axons live. Got two major risk factors that we follow: intraocular pressure and age, and the rest of the risk factors are relatively minor. And remembering that glaucoma damages retinal ganglion cells and decreases retinal ganglion cell function, these are really what we need to be watching closely in patients, not just their pressures at their visits. We want to be looking for loss of function. We do that mainly through visual fields, for example, the Humphrey visual field. And there are other approaches that are in investigation, but are much less reliably used. And then loss of structure, and traditionally this was done exclusively through fundus photography, and that has transitioned to be mostly through OCT now, and I'll talk about both of those briefly. So for function, we use visual fields. Here's the HFA3, the most recent release, and what we're really measuring here is the hill of vision with the highest vision centrally in the fovea of the macula, and then that vision typically falls off. And it's against that typical hill that we're comparing our patients when we normalize our data against normative databases. And we're all used to the very typical printouts from these. Here's a 24-2 in the right eye of a patient with a very normal looking visual field. And we often glance quickly at the grayscale, but really try to focus on the pattern deviation where we're normalizing that patient against their age group, against their peers. And here in the left eye of this patient with very mild glaucoma, where we can see this arcuate defect breaking into a nasal step here superiorly, again, a very typical mild glaucoma patient. And how we now use these to get into better levels of testing and progression is the key. Here you can see in this same patient where their right eye has been stable over many years, here from 2002 to 2009. Their left eye from the same period has really shown some progression, and we can see both in the grayscale as well as in the pattern deviation shown here in the rightmost column. And this is a very typical long-standing printout that probably most of our glaucoma specialists and clinical practitioners are used to. We do have the problem in visual field testing, of course, that it is subjective. Here's a patient from 2008 to 2009 that looks like their glaucoma got better, but no, they were not taking a neuroprotective agent or a neuroenhancing agent. Indeed, they just had a bad day in 2008, or maybe they had all of their coffee needs that morning fulfilled in 2009. And so we know this kind of variability gets in our way. And that's where having more data and looking longitudinally starts to become really, really critical in glaucoma patients. There have been some exciting advances in the functional testing with visual fields, particularly I could highlight for the HFA3. The CETA Faster 24-2 is now making this a much faster exam in our patients. And I will say that during COVID-19 now, minimizing clinic time, face-to-face time with our patients, with our technicians, with our providers is even more motivating than it was before. This new testing algorithm uses the same normative database and saves time through adaptive protocols, and also using gaze monitoring and false positives for quality control. And so all of that has conspired to make this a faster test, especially in a normal towards mild patient. Obviously takes a little longer in a more severely affected patient. Also very important to remember that glaucomatous damage of the macula is common and can occur very early in the disease. And this can be missed or underestimated with the 24-2 standard visual field tests. And so that use this typical 6-degree grid between points. And so we really do want to sometimes leverage looking more centrally, especially in patients for whom we have high suspicion. And so ZEISS has rolled out this 24-2C algorithm, and you can see in a printout on the right the additional data points that are now being collected in the central field. And these extra 10 points in the central field mimic and correlate with the cognitive points on a 10-2 Humphrey visual field. And the idea that I like here in the 24-2C is the ability in one test in a similar time frame to collect what otherwise we might have to collect through a 24-2 and a 10-2 collected serially. And so that's a real nice advantage. There have also been a number of advances in the visual field analyses that I think are really helpful when looking longitudinally at our patients over time. And I'm going to highlight a couple of those right here as we get into some of the cases. This is the guided progression analysis, or GPA, and these are a couple of the printouts that we've been used to seeing for a number of years already. On the left, you can see the likely progression indicators, including points marked with X's that are now too low to detect progression, points with an open triangle that show possible progression, points with a mixed triangle that show more likely progression measured over 2 subsequent fields from the baseline fields, and points with a likely progression measured in 3 fields since the baseline fields captured over time. Very useful to get to see this kind of printout, and also mapping the visual field index over time. And this is something that I find very helpful. In fact, I almost never print out the single page view anymore or use the single page view. We really use this longitudinal view, and the ability to look at recent slope, and I'll show you error estimates around that slope, as well as the prediction of where that patient's going to go in the next 5 years, and to be able to see that mapped over their age and really incorporate a personalized approach to that patient's care, whether they're younger versus older, whether they're in relative good health or have significant comorbidities. Understanding that patient's level of disease and direction of disease, I think, is very helpful when we're thinking about customizing our treatment for patients. Now, we use the Forum Glaucoma Workplace, and this has some new advantages with the new machines, including the Rely feature, where you can click on a visual field point, and because the machine is now taking images of the eye, useful for gaze tracking, but also for this feature where you can say, geez, if I'm suspicious of this point, Is this point really depressed? Has the patient had their eyes open, for example, or am I catching a lot of blinks coincidentally when that point's being assayed? Here you can see an example where the 3 times this particular point was tested, 2 of those 3 point times the patient actually didn't even have their eye open. And these other examples where the patient did seem to more reliably have their eye open and centered during that examination of those points in visual space. Let me come to structure, and then I'm going to tell you how we bring it back together in some case examples. Now, again, traditionally we use fundus photography, and we still need to examine the optic nerve. Whether we photo document it or document it carefully in our notes is obviously up to the practitioner. But looking for and documenting elements that we don't yet capture well on automated or infrared imaging, such as peripapillary atrophy. And here you can see in this relatively mildly affected patient a very thin rim of peripapillary atrophy, as well as disc hemorrhage, not captured on this particular patient. Very important to be examining for these and documenting them. So we're not yet ready to replace the examination of our patients in this fashion. We do traditionally do a number of measures that we know are quite unreliable, both in a test, retest, evaluation within a practitioner, let alone between practitioners. You know, we want to look at the disc size and the cup to disc ratio. We want to use these to look for rim thickness and focal notches or thinning. And this is now an approach. These elements of fundus photography and disc examination are now being much more reliably captured in OCT imaging and the metrics that come through on your OCT report. So I think there are elements of fundus photography that we are now beginning to replace with our OCT examination of the nerve, but still an important role for examining the nerve. So let's turn to optical coherence tomography, OCT. As everyone knows and has been introduced, we use infrared light reflectance to identify the relative separation between surfaces, that is to say the retinal layers. And again, here's one of the older views that many of us may have used for many years, where again, we can appreciate the normal ranges, the superior and inferior thicker bundles of optic nerve axons, the patient showing their measurements in the black line, always remembering to look for any potential artifact by at least glancing at the unfurled reflectance layer here of the retinal nerve fiber layer going around the disc. And then in recent years, again, appreciating the importance of viewing the macula and the retinal ganglion cells and their dendrites, moving towards the macular cube and macular ganglion cell complex, which looks at a combination of the ganglion cell layer and the inner plexiform layer, where retinal ganglion cell dendrites live. Very important to be looking at the macular cube. And we now, as a standard on all glaucoma patients, when we're doing their OCT imaging, we take both the macula and the optic nerve retinal nerve fiber layer. It's been suggested that either of those two are able to detect early glaucoma fairly similar to each other, but later in the disease, when you're hitting a floor in the nerve fiber layer, the change can still be detected in the macular ganglion cell complex. So that's why I think it's really important to be capturing both. Some of the newer imaging technologies, including in the debuting Plex Elite technology, are going to allow us wider field views that allow us to capture both the macula and the optic nerve in a single imaging session. But even without that, using your standard machine to capture both, I think, as a standard in your glaucoma patients, I think is a very, very good idea. I certainly would recommend that. So how are we seeing some of the new views? I think some of the new views and analyses are particularly interesting and in particular very helpful in the clinic to be using. Here's a patient with moderate disease in the right eye and more severe disease in the left eye. And this is one of the views I find very helpful. It brings together in a single view that day's visual field and OCT testing into a single view. This is very good. It allows you to very quickly assure yourself about correlation. For example, here we see some superior thinning on the nerve fiber layer that corresponds well with the inferior arcuate defect and nasal step in the right eye. And the more severe disease, superior and inferior in the left eye, is captured again in the superior and inferior thinning. Being able to see both the nerve fiber layer and the ganglion cell complex in a single view, again, very helpful, I think, when you're looking for reassurance or clarification on a given patient's situation when it comes to decision-making for treatment or treatment advancement. So let's talk about how I've been using this in a few of the recent cases. Here's a case of a woman. She's about 65 years old. She's got open angle glaucoma. Been following her very closely over the last years and have a question about whether she's progressing despite her maximally tolerated medical therapy that she's on right now. And here we can see from 2015 to 2019, if you just glance at the grayscale and even at the pattern deviations, it's not that easy to detect whether there's any worsening over time. She's now at the p less than 0.5% level on many of the spots in here. And this is where turning to some of the guided progression analyses is really helpful. Here we can see over these past years all of her visual fields, plotting the visual field index, which tracks very closely but is not identical to the mean deviation. And here we can see again that this is suggesting a rate of progression on the scale of -2.5 index points per year. She has obviously one day that she had a poor performance day. We can go into the computer and tell it to exclude that point as a poor performance day. This is very helpful, but digging deeper into her combined structure and functional imaging, I think, is very helpful. Here again is that single time point view, where again we can see, for example, the inferior thinning and superior field loss. She has that also in the left eye, even though I'll focus here on the right eye. This is a really helpful unit now in Forum, is the structure function GPA. And in this unit, we can actually pull down whichever elements we want to look at next to each other. Here I've put together the mean deviation on the right eye, the visual field index on the right eye, and I've put that together with the RNFL thickness, and you can see she's kind of, at or around the floor for her in that, as well as the ganglion cell thickness taken from the macular OCT. And although her RNFL is probably hovering, within a margin of error around her normal, we might get concerned about whether recently she's showing a thinning in the macular ganglion cell complex that may correlate with some of the recent sloping off of her visual field, especially over this last year or two. And so again, being able to put this together into a single view and look at structure function together, I think is very helpful for decision making about patients like this. This is a patient that we're going to continue to watch very closely because of this fairly clear indication that she's continuing to lose macular tissue while she declines on her visual field. And then zooming in this structure function report on the visual field plus the ganglion cell layer, this is a beautiful view again that captures the visual field alongside the retinal nerve fiber layer and macular views. And again, look at the beautiful correlation between her macular loss and her visual field loss. And again, although you might have trouble seeing this progression happening here on the visual field, putting it together next to the structure really does help us define that there is some evidence of progression that we want to continue to watch closely. She's had in her most recent follow-up here, September 2019, shown actually, a fairly stable look. So again, we're going to watch her very closely. There is further data that I won't dig into in detail, but there's further data lower down in the report if you want to get into the actual numbers and really look at some of the different metrics, including things like rim area or breaking it out by quadrant, inferior, superior quadrant, etc. Here's another interesting case. This is a 92-year-old male. He's got advancing pseudoexfoliative glaucoma that's in the left eye. His right eye, although he has pseudo-X in that eye as well, has been spared as much damage over the last years. And again, here's one of his recent exams. He came in and saw me yesterday, or just 2 weeks ago in April. And again, looking field by field, it looks a lot like progression. Here you can see 2014, 2016, 2017. It looks like he's getting worse. You get the sense from the grayscale and also from the guided progression analysis and the triangles on the right that compared to the baseline through 2019, continuing to get worse, and here 2019, even 2020. Really a concern for progression in this 92-year-old. And you might think, gosh, it's time to get even more aggressive. Maybe I've got to think about taking a 92-year-old into surgery. Important to look at the treatment, though, that he's had along the way. When we look at the progression analysis here by the visual field index, it's telling us that he's really progressing quite quickly at -3.5 index points per year. And this is an otherwise healthy and fairly robust, certainly mentally completely with it, 92-year-old. And so, we may be guided by this to think about bringing him to surgery, but then it turns out that we want to remember that in his particular case 2 years ago, we had actually greatly increased his topical therapy, and we had decreased his eye pressure to a new target pressure. It was running around 18. We got him down to the 13, 14 range in this eye. And so what we did to account for that is actually we said, okay, that happened right here. Let's go into the forum and reset this as his new baseline. Important to do that so you don't get fooled in a busy clinic to think someone is still progressing. When we reset those to his baseline, well, now we see that he's been fairly stable. And in the 6 fields that we have so far, 4 following that more recent baseline over the last 2 years, we see now actually he's progressing at less than 1 visual field index point per year. That gives us a much longer run rate that we might not have to bring him to surgery, and we can continue to watch him closely and consider him much more stabilized after having advanced his medical therapy. Finally, many of you know that I'm deeply involved in clinical trials for neuroprotection, and in fact, it's very exciting these days because we have new sets of therapeutic candidates that are targeting the retinal ganglion cells and their axons in the optic nerve rather than the pressure function in the front of the eye. And these are designed to promote neuroprotection, which would be to slow the decline, or as we now say, flatten the curve in coronavirus days now, or even to promote neuroenhancement, which is a term that we've taken from the Alzheimer's literature. And the idea there is that some of these drugs may actually give a booster shot to the sick retinal ganglion cells and improve their structure or function. That's the hope for some of these. And leveraging this kind of advanced visual field and structure OCT analysis in these clinical trials is really helping us to understand how they're working. For example, we completed a phase 1 trial for CNTF. This is using an implant that goes inside the eye and secretes ciliary neurotrophic factor, which is one of the trophic factors that in animals strongly supports retinal ganglion cell survival and regeneration. The phase 1 had very positive safety data and some hints of efficacy. So we're actually now in a phase 2 randomized controlled trial with 54 patients enrolled between these sites shown here. The patients are randomized to getting the implant versus sham surgery, no implant. But if they get the sham surgery, they can actually cross over a year later and get the implant in their eye in that second year. And this is really interesting. I'll show you a case of one of these patients who turned out to be in the sham group and then crossed over into the implant group. And so here you can see over the last couple of years of the trial how this patient has been doing, again, using this really helpful view of the structure and function guided progression analysis, where we're combining a look at the visual field index and the retinal nerve fiber layer thickness, and looking at the both the profile, which can show me where here superior temporally, there's an evidence of some change right there. And then we can look at the average retinal nerve fiber layer thickness and the average ganglion cell macular ganglion cell complex thickness over time. And there's some evidence like, Jesus, there's a slope upward here, particularly during that second year. And it certainly looks like we're seeing that fairly clearly in the nerve fiber layer and the ganglion cell complex, not as clear when we simply map the visual field index. But we have to remember, again, like in the last case, this is where she actually got her new treatment. The first year she was in the sham group. And during that first year, you can see some evidence of decline and this hint of possible increase through the second year. And again, we can look at this point by point through time and look at this change, for example, in the ganglion cell complex, very important to be looking in the macular ganglion cells, you know, and to ask, geez, it looks like there's actually a lessening of the thinning that we had seen early in her disease course. And when we reset the baseline to coincide with her implant, with her therapeutic change here, then we can see more clearly mapping the mean deviation in this case, some evidence of possible ramp up of her mean deviation on visual field testing. And we can break that out. Here we're actually looking at the mean deviation of her inferior field versus her superior field. Some evidence for change in both, hard to say, we don't have the statistics yet across the entire population. But wouldn't you know, we see kind of a matching if we put the inferior mean deviation next to the superior retinal nerve fiber layer thickness, right? Because that's the coordinated structure function match. We can see a more dramatic evidence of change in her superior nerve fiber layer correlating to her inferior mean deviation functional assay. Less evidence in her inferior nerve fiber layer correlating with her superior visual function. So again, the ability now in the glaucoma workplace using Forum to break out these different elements and really dig deeper into your patient's structure function, I think that's really having a lot of impact in our ability to make more intelligent decisions looking at progression and decision-making around treatment for our patients going forward. So in summary, this clinical decision-making, I think, is being greatly aided by advanced measures of visual function, by visual field testing, combining those with advanced measures of retinal and optic nerve head structure by OCT, and combining both of those with useful views and analyses of the structure function progression. So with that, I'll thank you very much, and I'm happy to entertain any questions as we have time. Thanks very much.